About 60% of newborns develop jaundice during the first week of life. This is usually harmless. However, infants with severe jaundice may develop bilirubin toxicity, which, if not treated quickly, may lead to permanent brain damage, commonly called kernicterus. In this presentation, you will learn about kernicterus, how it affects newborns and survivors, why it is so common in Africa, the Middle East, and Southeast Asia, and what can be done to prevent it. The name Kernicterus was first assigned by a pathologist to describe icteric or yellow staining of specific regions of the brain found in newborns who died with severe jaundice. The affected regions control coordination, hearing, and specific muscle groups, but notably areas of brain involved in cognitive functions are spared. Why do newborns develop jaundice? Jaundice is created by elevated plasma bilirubin, a yellow pigment produced from hemoglobin when red cells are destroyed. Red blood cells are normally replaced about every 100 days. Bilirubin is eliminated by the liver into the intestine, but liver enzymes needed to excrete bilirubin have decreased activity during the first week or more of life, resulting in neonatal jaundice. This graph illustrates the rise of plasma bilirubin in a population of healthy term or near-term infants during the first week of life. Plasma bilirubin levels usually peak on the 5th day of life. At that time, 95% of healthy term newborns will have a bilirubin level below 18 milligrams per deciliter. The risk for bilirubin neurotoxicity in healthy term infants is low if the bilirubin level is maintained below 25. If excessive bilirubin is produced while the liver has limited ability to eliminate it, then the serum bilirubin concentration can reach dangerous levels. The most common reason for high bilirubin production is increased red blood cell destruction, which we call hemolysis. Here are the most common causes of severe hemolysis in newborns. Jaundice from Rh or ABO incompatibility may occur when a mother with type O or Rh negative blood has an unborn baby with a different blood type or is Rh positive. If the baby's red cells leak into her circulation, she may develop antibodies to them that cross the placenta and attack the baby's red cells. G6PD enzyme deficiency is an inherited condition that increases the vulnerability of red blood cells to several drugs and chemicals. It is the most common cause of severe jaundice in sub-Saharan Africa and is also prevalent in many regions of the Middle East and Southern Asia. Severe bruising and certain infections may also increase red cell destruction. If the bilirubin level becomes high enough to affect brain function, infants become sleepy, often irritable, and stop nursing well. These are signs of mild acute bilirubin encephalopathy, or ABE. They will resolve with intensive phototherapy, and long-term consequences are rare. But if not treated quickly, mild ABE may progress to severe acute bilirubin encephalopathy. This infant has severe ABE. His head and back are arched, his extremities are stiff and extended. His cry is shrill and he is unresponsive to feeding or comforting. He will likely have permanent brain damage from kernicterus if he survives. Babies with acute kernicterus often have an anxious, blank stare, rigid facial expressions, poor eye coordination, and uncoordinated sucking, as does this 6-day-old baby in Nigeria. Older patients with kernicterus have a spectrum of clinical manifestations. Some only have hearing loss, but most patients have varying degrees of abnormal muscle tone and uncoordinated movements. Dystonia also leads to difficulty in speaking and eating. In addition to nervous system targets, bilirubin can stain and impair the development of deciduous teeth. But it is important to remember that most patients with severe kernicterus have normal intelligence, although they may be locked into a painful body that does not work. This is Rasha, a 4-year-old Egyptian girl with a becoming smile. She has severe dental dysplasia typical of kernicterus, and she has very poor truncal tone and head control, but increasing tone in her extremities, with uncoordinated movements of hands and feet called athetosis. She has severe hearing loss and difficulty coordinating muscles needed for eating and speaking. This tragedy is compounded by the fact that kernicterus can easily be prevented with appropriate treatment, even in most cases of severe hemolysis. Why is kernicterus so common in low-resource settings? There are many reasons, but 4 factors stand out. First, in sub-Saharan Africa and many low-resource countries, G6PD deficiency is common, often resulting in severe jaundice if not treated quickly. Secondly, a low awareness of the dangers of jaundice among parents and health workers often results in delays in seeking care. Babies with severe ABE and kernicterus are most often brought to the hospital because they are sick, not because they have jaundice. Third, the failure or inability to measure plasma bilirubin concentration impairs doctors' abilities to identify newborns in need of treatment. And finally, many treatment facilities lack high-quality phototherapy to treat jaundice. Overcoming these barriers to care requires action on several fronts: education, risk assessment, and effective treatment. The first step in preventing kernicterus is to increase public awareness about the risks of kernicterus and to train mothers and health providers how to detect and manage neonatal jaundice. In regions where there is a high expression of G6PD deficiency, parents need to avoid substances that might trigger severe hemolysis, such as mothballs, camphor, henna, and menthol-containing ointments, such as mentholatum. Where specific testing for G6PD activity is not available, it should be assumed that all newborns are at risk. Parents need to know how to detect jaundice by compressing the skin and to seek immediate evaluation when it is discovered. A delay in seeking and receiving care is the most critical correlate with severe jaundice and kernicterus in any country. How effective is teaching mothers about jaundice and preventing ABE? This study, conducted in Nigeria, documented a high association of combined antenatal and postnatal instruction with early care seeking and with a decrease in ABE. 29% of babies admitted with jaundice had signs of ABE when mothers did not participate in the maternal instruction program, compared with 1.5% of admissions when mothers were trained. Infants of mothers receiving jaundice instruction had lower incidences of mild ABE, severe ABE, and death. The increased risk of home birth disappeared if mothers had antenatal care and were taught. When mothers seek care for a jaundiced newborn, the health provider at the community clinic or hospital must decide whether treatment is necessary. Knowing the plasma bilirubin concentration is critical in making this decision. Unfortunately, most rural clinics and even some hospitals do not have the resources to measure bilirubin. Several point-of-care instruments are available or under development to meet this need. The simplest are visual aids comparing skin color with reference color, pioneered as the Ingram icterometer decades ago. More sophisticated methods to estimate plasma bilirubin by skin color include transcutaneous monitors and, more recently, smartphone applications. Point-of-care assays for plasma bilirubin are available or are being developed. A drop of blood is placed on a blood plasma separator and the plasma diffuses onto a test strip. The bilirubin concentration in plasma is determined by measuring the intensity of yellow using handheld reflectometers, spectrophotometers, or smartphone cameras as detectors. Selecting the optimal screening device for use in rural clinics, secondary hospitals, and treatment centers should consider cost and accuracy needed for each setting. Having acquired an estimation of the bilirubin concentration and clinical condition of the infant, the next step is deciding on the need for treatment and coordinating with the treatment center. Consensus treatment guidelines throughout the world are based on modest epidemiologic evidence and, especially in low-resource countries, on socioeconomic factors influencing access to care. This chart represents the American Academy of Pediatrics consensus guidelines for term and near-term infants in the United States. The range of recommended treatment thresholds for 5-day-old infants range from 15 to 21 milligrams per deciliter, depending on gestational age and other risk factors such as the evidence of hemolysis. Recommended guidelines for phototherapy in affluent countries with close patient follow-up and reliable treatment resources may not be applicable to low-resource settings, where access to effective phototherapy may vary. These recommendations for phototherapy were used for published clinical studies in Nigeria and approximate the high-risk category in the AAP guidelines. The conservative recommendations recognize uncertainties in laboratory accuracy and the quality of phototherapy in some treatment centers, as well as access to care problems for families in remote communities. It is important for each country to establish guidelines for treatment based on unique resources and cultural features of their society. Guidelines for phototherapy maintenance are supported by better evidence than our guidelines for their use. Effective phototherapy requires a minimum light irradiance of 10 microwatts per centimeter squared, measured at the newborn's abdomen or about 5 centimeters above the mattress. Ideal irradiance for term and near-term neonates is equal or greater than 30 microwatts per centimeter squared. This is sometimes referred to as intensive phototherapy. Light intensity of phototherapy units should be monitored every 2 months using an irradiance meter. Unfortunately, most irradiance meters are expensive. If irradiance cannot be measured, daylight fluorescent tubes should be replaced about every 2 months or 1,000 hours of use. Techniques have recently been developed to use filtered sunlight in rural areas where stable electric power and traditional phototherapy are not available. Filtered sunlight uses special materials that eliminate harmful ultraviolet radiation and has proven effective in lowering bilirubin levels in term infants. Safety protocols are currently under study, and when approved, the system will become available in rural settings to supplement traditional phototherapy. Slowly replacing an infant's blood with donor blood may be needed when a baby has acute bilirubin encephalopathy or when phototherapy is not effective in reducing a dangerous bilirubin level. Eradicating Kernicterus in low-resource settings is an achievable goal if 4 steps are followed. First, Educate parents and health providers how to recognize jaundice and to seek care immediately. There is evidence that parent instruction is most effective if provided in antenatal clinics with postpartum reinforcement. Introduce low-cost point-of-care methods to screen bilirubin levels in clinics as well as in hospitals. Third, improve networking between rural clinics and treatment centers to facilitate consultations and referral. And finally, install and monitor effective phototherapy units. Kernicterus is easy to prevent, but impossible to cure. Prevention is not complicated. The cost of education, evaluation, and treatment is low compared to the cost of lost lives and caring for patients with damaged brains.